I think our next speaker is I don't know how to characterize him. Is he a scientist? He's an electrician? He's a cardiac electrophysiologist? He's just too smart for us. It's my pleasure to welcome Dr. Valderrábano. Dr. Valderrábano is a professor of cardiology. He's a division chief of cardiac electrophysiology here at Houston Methodist Hospital. And he's a very nice guy. I tell you why. I said, Miguel, we'd love for you to do one 15-minute session. He says, no, come on, I'll do all 45 minutes. Dr. Valderrábano.
Well, thank you, Alpesh, and thank you all for being here. So I'm going to discuss the electrical part of cardiology for the non-cardiologists, and we're going to focus on atrial fibrillation, which is probably the disease that overlaps the most between cardiology and internists and other practitioners. And when I looked at the program, I saw that we had 3 different talks. They're all centered in AFib, and they're all centered in the key management challenges that AFib poses to the practitioner, which are anticoagulation for stroke prevention, ablation, and devices for stroke protection. So let's just go over, step back a little bit and go over some general concepts about AFib. So AFib is disorganized atrial activity, and that leads to very rapid activations in the atria. If you measure atrial heart rate, could be as high as 500 beats per minute. Now, of those crazy beats in the atria, every third, every 10th, every other goes to the ventricles. So the patient will have an irregular pulse, as you can see by the irregular QRSs. We know mechanistically that many of the atrial fibrillation events initiate by extra beats, ectopic beats that arise from the pulmonary veins, and that has relevance to how we treat it mechanistically. But in general, the key things here is somehow electrical activity in the atrium gets disorganized and the upper chambers just quiver. So the atria quiver, and that has profound implications not just for the patient's symptoms, but also for the patient's prognosis. The biggest danger of AFib is because the atria are quivering, they do not have a meaningful contraction. So the upper chambers are just quivering like this. Blood can become very stagnant, and the atria have crevices in the appendages where clots can form when blood doesn't move. Therefore, if a clot forms, it could embolize to the brain and give you a risk of stroke. So the biggest prognostic implication of AFib is a risk of stroke, which depending on which subset of patients with AFib you look at, could be anywhere between double risk of stroke to up to 5 times the risk of stroke compared to patients in normal rhythm. And that translates itself into a higher risk of mortality overall. Patients with AFib tend to die younger and sooner than patients in normal rhythm. And that is important because it's not just about the symptoms. We need to take care of the patient as a whole. More recently, it actually has been reported that atrial fibrillation can actually be associated with an increased risk of dementia. And we used to think, well, it's just dementia because maybe it's just strokes. You know, patients may have subclinical strokes that may not have a motor deficit or slurred speech or any other visible or noticeable symptom, but they just have cognitive decline. And that's been reported, the statistical association between AFib and all kinds of dementia, not just vascular dementia from strokes, but also senile dementia and Alzheimer's. So in a sense, AFib is a sign of aging of your vascular system that actually can affect the cerebrovascular system and lead to dementia. So it is a big problem, and it is here to stay. If you look at the statistics of AFib, looking at non-paroxysmal AFib, not just episodes of AFib, but patients that are continuously in AFib, right now we have up to about 5 million people in the country with AFib, and it goes up with age. As many as about 10-15% of patients older than 80 will have atrial fibrillation. So it's here to stay, and with the aging of the population, it's going to be more of a problem. A few definitions, again, for the non-cardiologists, so that we are clear on the terms. We define different kinds of AFib based on the different temporal patterns of AFib. So paroxysmal AFib is one that stops by itself. And we basically define a cutoff of 7 days. So if you have AFib that comes and goes and doesn't ever last longer than 7 days, we call that paroxysmal. You may have paroxysmal AFib and have 2 episodes per year that last 1 minute, or you may have paroxysmal AFib with a 1-hour episode every day. That's still paroxysmal AFib because it stops before lasting more than 7 days. So when you have paroxysmal AFib, we tend to also talk about the AFib burden. How much AFib does a given patient have? And like I said, patients may have very little AFib burden where they may have 1 minute or 2 of AFib once a year versus patients that have daily episodes of several hours. Persistent AFib is continuous AFib that lasts more than 7 days. For prognostic purposes, when it comes to ablation and its response to ablation, we define long-standing persistent AFib as that has been there continuously for a year. So 12 months of AFib, continuous AFib, that is what we call long-standing persistent. Now, you will hear also the definition of permanent AFib. Permanent AFib refers more to a decision that the patient and the doctor makes than to AFib itself. So permanent AFib is one in which the patient and the doctor have decided that they're not going to try to fight. They're not going to try to reverse. They're not going to try to cardiovert or get out of the AFib. We just assume that the patient is going to be in AFib for the rest of their lives. We call it permanent AFib. And that, again, has nothing to do with the patient. The patient's AFib itself is a decision that the physician makes with the patient. It's important to distinguish non-valvular versus valvular AFib. Valvular AFib, then we refer to it as that occurs mostly in the setting of rheumatic heart disease, mitral stenosis, and that has different implication and different response to therapy. And most of the studies that have been done in AFib are related to non-valvular AFib. So we need to exclude patients that have rheumatic disease. So what is the problem with AFib? That, again, we can get a clot forming here. This is the left atrial appendage. It's a little pouch of the left atrium. When this pouch doesn't move, when it just quivers, blood becomes stagnant, and stagnant blood likes to become a clot. And then this can go to your brain. That's why this area, this anatomical structure called the left atrial appendage, has become the focus of our attention lately. So how do we prevent stroke in AFib? Basically, two different categories. One, systemic anticoagulation with either warfarin or the new oral anticoagulants, abbreviated as NOACs, or we can try to close the left atrial appendage. We can put a plug, different kinds of devices, of which I'm going to be focusing only on Watchman, which is the one that's approved. But first, we will have to discuss oral anticoagulation, which is the first talk in your program. Which one you select depends on individualizing risk benefits of each of these strategies for each of these patients. So a key component of the assessment that a general practitioner has to make on a patient with AFib is what is the risk of stroke? Because not everybody has equal risk of stroke. We use this so-called CHADS-VAS score. And it's one thing that I want you to take home out of this talk is the CHADS-VAS score. Every patient with AFib has to have that assessment. This acronym the C stands for congestive heart failure, history of congestive heart failure. The H stands for hypertension. The A2 stands for H more than 75. You get 2 points against you if more than 75, but if your H is more than 65, you get 1 point. A prior stroke or TIA is the S2. You get 2 points against you if you had a prior stroke or a TIA. What that means is we're really good at predicting the second stroke, not so good at predicting the first stroke. When the patient has had 1 stroke, we know they are really high risk of having a stroke. Vascular disease, if the patient has carotid disease or peripheral vascular disease, we know that has been associated with an increased risk of stroke. And females, for reasons we don't understand, have a higher risk of stroke. So that the S stands for this S means sex category. So congestive heart failure, hypertension, H more than 75, diabetes, I missed that here. The D is diabetes, S2 for stroke, vascular disease, H more than 65, and sex category. You do these counts, and then you come up with a number that would indicate the risk of stroke. Now, one thing that I want to point out is, where is the left atrial appendage in this whole risk stratification scheme? It's not there. It's an important reflection that we need to make, that we're very good at looking at associated factors congestive heart failure, hypertension, that really don't have much to do with AFib mechanistically and the mechanism of AFib-related strokes. But nevertheless, these are the risk factors that have been validated. And when you look at Chad's VASC and the risk of stroke per year, it's a pretty much linear relationship. A few words about the CHADS-2 score, which is a precursor of the Chad's VASC. It did not include any points if you were older than 65, and it did not include any points if you had vascular disease, and it did not include any points if you were female. So it was pretty good also estimating the risk of stroke, very much a linear relationship. But it failed to distinguish those patients with so low risk of stroke that you don't really benefit from anticoagulation. The CHADS VASC of 0 patients, males of age 45, completely healthy athletes that have AFib, do not have a very high risk of stroke. And in those patients, the risk of anticoagulation is actually greater than the risk of stroke with AFib. So what have we tested over the past 5 decades of AFib management for stroke prevention? Warfarin was the first drug that was validated as a strategy to prevent strokes in AFib in several studies. I don't want to bother you with the details, but suffice to say that these are 6 studies that tested the risk of stroke in patients treated with warfarin versus placebo. And in pretty much all of them, clearly the relative risk reduction favored warfarin compared to placebo when it comes to risk of stroke. It's interesting to point out these were studies that included 400 patients, most of them, so relatively small studies for the size of a current clinical trial. So with 400 patients, they were able to show that warfarin made a difference. Now, we had warfarin for a long, long time as the only treatment option for stroke prevention in AFib. 2009, the RELY study was published. This study looked at a competitor to warfarin, dabigatran, a different mechanism of action, direct thrombin inhibitor. And this drug had the advantage that you just take a fixed dose and you get a predictable level of blood thinner. What happened with warfarin is that the way it works is by antagonizing vitamin K in your diet. The more vitamin K you take in your diet, the more warfarin you need to achieve a given level of anticoagulation. So patients need to be checked. We have this lab test INR, which you're all familiar with, that we need to check on patients that are on warfarin. And sometimes every week, sometimes every month, we need to keep checking on patients to see whether they have the appropriate level of blood thinning. Because if one day they eat a lot of broccoli, then they're going to need a higher warfarin dose to get the same level of anticoagulation. And it would happen that if the patient suddenly stops eating vegetables and the vitamin K intake is decreased, then the same dose of warfarin will lead to excessive blood thinning and risk of bleeding. So dabigatran was the first alternative to warfarin, was presented in the RELY study that included 18,000 patients. No more of these 400 patient studies, 18,000 patients. It took to show convincingly that dabigatran led to a combination of decreased embolic events. This is stroke and systemic embolism risk. Dabigatran at 150 milligrams twice a day led to significantly less stroke and systemic embolism. Dabigatran at a lower dose was better than warfarin, but not as much. And it was interesting that when you look at how it worked in terms of the specific types of stroke that patients had on dabigatran versus warfarin, hemorrhagic stroke, the overall hazard ratio was 38%. That means that patients on dabigatran had a reduction in hemorrhagic stroke of 62% compared to warfarin. Very little hemorrhagic strokes. Ischemic strokes were actually quite similar. So a twisted way to interpret this is, this drug is as good as warfarin at preventing a clot from forming in the appendage and going to your brain and giving you ischemic stroke. But it's also much better at preventing a stroke from becoming hemorrhagic. And those are the strokes that kill you. It was interesting that when you compared dabigatran at the fixed dose versus warfarin, but you only take patients that took warfarin the right way. That means with INRs between 2 and 3, it turns out that it was no different. When the time in therapeutic rate was more than 72% of the time. So if the patients had INRs between 2 and 3 most of the time, or at least more than 72% of the time, the curves of dabigatran at either dose versus warfarin were very similar. Dabigatran made a big difference when you look at patients whose time in therapeutic rate was a lot lower. So the patients that cannot handle warfarin the right way and have wide oscillations in the INRs are the ones that really look much worse compared to dabigatran. The second anticoagulant drug that came into play was Rivaroxaban, also called Xarelto. It was an interesting drug in the sense that pharmacologically it's a drug that should be taken twice a day. But the manufacturer saw an opportunity of beating dabigatran. Dabigatran is also taken twice a day. And what they did is they studied the drug as taken once a day. And they took a much higher risk population of patients, but still, they did show that stroke or embolism were reduced in patients with Rivaroxaban compared to those on warfarin. And a similar story, the hemorrhagic stroke rate was a lot lower in the Rivaroxaban patients compared to those of warfarin. The ischemic stroke, if anything, might have been a little bit higher in Rivaroxaban. So again, these drugs are better at preventing hemorrhagic strokes than warfarin is, and they are equivalent at preventing ischemic strokes. The third NOAC that was presented and approved for AFib is Apixaban, taken twice a day. Similarly showed decreased stroke or embolism compared to warfarin. Perhaps more impressively was the risk of bleeding. Patients on Apixaban will have a very significantly decreased risk of bleeding compared to warfarin. And in sub-analysis, they actually showed that Apixaban had a rate of bleeding that is identical to that of aspirin alone. So very, very reduced risk of bleeding. And again, a similar story when we look back at the ischemic strokes versus hemorrhagic strokes. These drugs are just as good as warfarin. Event rate is again similar in the two groups. 0.92 is the hazard ratio, so barely crossing the identity, basically. So no different, but much better at preventing hemorrhagic strokes, 50% less. The interesting thing is that these are clinical trials, right? And then the drugs get approved, and then you start getting TV ads and that claim that patients are dying because of these drugs because they have massive bleedings and fatal bleedings. And I just show you 3 large studies that showed less bleeding with these NOACs. So how do you put these two together? So the story came from the fact that when you're on warfarin and you bleed, you can reverse warfarin. You can give plasma, and right away you thicken your blood again, and you get rid of the anticoagulation effect. And if you have a few more hours, you can actually give vitamin K, and the liver would synthesize those factors and basically eliminate the effect of warfarin. So between fresh frozen plasma and vitamin K, you can reverse the blood thinner effect pretty quickly, if not immediately. These drugs, they stay in the body and they have an effect on circulating clotting factors. So if you give more clotting factors, the drug will bind to those. So if you give plasma, these drugs don't change anything. You still have blood thinning. So you cannot reverse in an emergent situation. You give plasma, but it doesn't really change much. This prompted a lot of anecdotal case reports, cases descriptions of someone died because they had massive bleeding and they couldn't reverse the blood thinner. Pradaxa, dabigatran, came up with an antidote that can be given right away and is approved by the FDA. But the underlying problem, this whole thing is a manipulation of the data, of the facts. The facts are that with these drugs, you actually bleed less. You bleed less because you don't have swings in the level of blood thinners. What kills patients on warfarin and on any drug is massive bleeds that are surgical bleeds. If you get into a car accident and you have a torn femoral artery and you're squirting blood, you need that artery surgically repaired. Sure, on your way to the OR, you're going to reverse the blood thinner, but what's going to save you is that surgical repair. If you have Pradaxa, you may bleed more on your way to the OR because you can't reverse a blood thinner. But those are very limited cases. Those are very anecdotal, small numbers of cases. If you look statistically, the bulk of the bleeding in patients that take warfarin is because their INRs are too high. And they have an INR of 10 and maybe a tiny ulcer, or they scratch their nose and they start bleeding. It's due to the high INRs. And if you prevent swings in the blood thinning level, you will decrease statistically the number of bleeding events. So the NOACs lead to less bleeding because the level of blood thinner is more steady and doesn't swing, and you would not have excessive bleeding out of excessive blood thinners. That's as simple as that. So when I have patients that ask me, oh, I don't want to take any of these drugs, well, it is true. These are blood thinners. That's the way they work. And bleeding is not a side effect, it's a front effect. They thin your blood. So if you have an ulcer, you will bleed. There are patients that cannot take blood thinners, period. And these are discussions that you need to explain patients, because otherwise they come with ideas that they see on TV ads, and that doesn't lead to any productive interaction with the patient. All right, what is the real bleeding outside clinical trials? Another point I wanted to make. So there's been studies looking at real life, outside clinical trials, bleeding incidents, and with warfarin it can get scary. I just showed you in clinical trials, the 3 clinical trials of the NOACs, bleeding on warfarin was about 3.54% per year. In real life, there's reports that report up to 30% 13% incidence of bleeding in patients that are older than 80 years of age. So bleeding is an issue with any of the NOACs, and like I said, more so with warfarin because of the swings in the INR. Let me just skip through this one. So if you look at the overall, this is a very busy slide, but it summarizes the data of dabigatran, Apixaban, Rivaroxaban, and the fourth one, which is Edoxaban. Similar rate of ischemic strokes. These are ischemic strokes in NOACs compared to warfarin in the 4 studies. A lot less hemorrhagic strokes in the NOACs compared to the warfarin groups. Less bleeding, and particularly Apixaban has the least bleeding of all the new anticoagulants. Mortality was about the same. Apixaban did reach statistical significance, but again, 2.2 versus 1.9. So overall, these drugs are an improvement, are an advance compared to what warfarin was, and this idea that you cannot reverse them and therefore you're going to die if you take them is not really something that is of practical implications.